Barbie here. Just a quick message before the video. You need to get my new ebook. It's called How to Win at Menopause, and it has all the tactics and strategies you need to win at managing your menopause your way, because the system doesn't exist to help you. It's available on Amazon, and you can use it on any device, and it's invaluable, inexpensive, and will be the ticket, your winning ticket to your ability to manage your menopause your way. Now time for the video. Greetings, dearies. Thank you for joining me today. You've come to Menopause Tailor, which is really a complete education on all things pertaining to your female health in general, as well as to your menopause in particular. Currently, we're embarking on a section that pertains to pre-menopausal women. And I am systematically presenting individual video tutorials on all the things that are absolute consequences of the female sex hormones that create your menstrual cycles. I've used this merry-go-round in all these videos on pre-menopause. It demonstrates how various pre-menopausal gynecologic issues turn your merry-go-round into one that is not so merry. And thus far, I've presented the merry-go-round of symptoms due to premenopausal hormones in video number 464, premenopausal mid-cycle pain in video number 465, premenopausal hormonal headaches in video number 466, premenopausal mood disorder in video number 467, and premenopausal endometriosis in video number 468. Well, this is video number 469, and it's going to be all about premenopausal polycystic ovary syndrome, also known as PCOS. Well, PCOS turns your merry-go-round into a hairy-go-round. I have actually already given you an entire unit on PCOS. It encompassed videos number 455 through 460. You see, my goal is to make sure you find what you need on my channel, regardless of whether or not you watch all my videos in order, like I tell all the menopausal women to do. I know that pre-menopausal women may watch only the videos with titles specifying pre-menopause. And if that's what you've done, you need to know that you'll get the information you need for your pre-menopausal PCOS here in this video, but you also need to know that your PCOS does not end when your pre-menopause ends. So be sure to watch videos number 455 through 460 in the PCOS unit, in order, of course. Together, they are much more complete than just this one video. PCOS is not a standalone topic in my book, premenopausal or otherwise. All of this PCOS education is a YouTube bonus. So let's delve into the topic of polycystic ovary syndrome. And we'll start with some statements on the general state of affairs with regard to PCOS. PCOS is quite common, and nobody really knows what causes it. It occurs in about 10% of women. That's 1 out of every 10 women. But the majority of the time, women with PCOS are unaware that they have it. And that's because the diagnosis is quite commonly missed, both by women and their doctors. And the reasons most people miss the diagnosis are many. As a result, PCOS is largely unrecognized, undiagnosed, and untreated. So I want to focus heavily on the reasons that PCOS is unrecognized, undiagnosed, and untreated. because overall the situation is entirely unacceptable. My goal is to impress upon you the importance of getting an accurate diagnosis if there is any chance whatsoever that you have it. And the earlier you make the diagnosis, the better, regardless of your age. Now, the first reason most people miss the diagnosis of PCOS is that the acronym is all wrong. The acronym PCOS stands for PolyCystic Ovary Syndrome. But there's a real problem with that name for this disease. And that's because the only organs designated in the name are your ovaries. But PCOS is not just a disease of your ovaries. Additionally, it is not just a disease that falls into the realm of gynecology. This means that while the reported prevalence is 10% of all women, the actual prevalence is much higher than that. The underlying abnormality in PCOS is a metabolic abnormality that affects multiple organ systems throughout your entire body and throughout your entire lifetime. So there are really 3 overriding system abnormalities for PCOS: dermatologic, reproductive, and metabolic. And there are 3 different organs that produce these abnormalities. They are your ovaries, your brain, and your fat. Plus, these 3 organs produce or utilize 3 different hormones abnormally: testosterone, luteinizing hormone, and insulin. And they all do so throughout 3 different hormonal phases: pre-menopause, peri-menopause, and post-menopause. So think about PCOS in terms of 3s. 3 system abnormalities, 3 organs, 3 hormones, and 3 hormonal phases. So I think PCOS should actually be the acronym for permanent cardiometabolic ovary syndrome. And in this video, you'll discover why. So let's go through these 3 organ systems and designate how they affect your pre-menopausal life. I'll touch on how they affect your peri and postmenopausal life too, but you'll need to watch videos 455 through 460 for more detail on all of this, and especially those 2 phases. I'm going to present this information according to symptoms. And I'm doing so because symptoms are what you'll notice. And the whole purpose of this lesson is for you to recognize PCOS as PCOS. So I'll do this in order of the most obvious symptoms to the least obvious symptoms. But you need to know that the least obvious symptoms are the most significant symptoms. So I'm saving the worst for last. The most obvious symptoms of PCOS in your premenopausal life are the dermatologic system abnormalities that can affect your skin and your hair. Notice that I said that they can affect your skin and hair. And that's because some women with PCOS have them while others do not. Anytime a disease causes symptoms for some people and not for others, it lends itself to a high rate of missed diagnosis. So this is another reason most people miss the diagnosis of PCOS. The possible dermatologic symptoms include hirsutism, acne, and male pattern hair loss. Hirsutism consists of excessive dark or coarse hair in a male-like pattern. Most commonly, this entails facial hair, chest hair, abdominal hair, and arm hair. This is why I call PCOS a hairy go-round. The acne of PCOS is cystic acne, and usually cystic facial acne. It's not just an occasional zit here or there. It's usually deep, scarring, even painful acne. And it can occur on your face, your chest, your chin, your whole upper body. And the male pattern hair loss consists of thinning hair at your temples, followed by thinning on the top of your head, just like a balding male. Women who have these dermatologic symptoms of PCOS have them in widely varying degrees. This is yet another reason PCOS gets missed so much. And remember, some women have none of them at all. They are usually lifelong problems for those unfortunate enough to have them. And the problem is that the range of possibilities is endless. If you have any of these dermatologic symptoms as a pre-menopausal woman, go to your gynecologist and demand that they assess you for PCOS. There is much more at stake here than just your hair and your skin. The second most obvious symptoms of PCOS in your premenopausal life are the reproductive system abnormalities that can affect your periods, fertility, and pregnancies. And those are just the things that can affect your premenopausal life. As I said earlier, your PCOS is not limited to your premenopausal life. So even though your reproductive life is limited in time, these reproductive symptoms of PCOS are not. And notice again that I said PCOS can affect your reproductive system. And that's because some women with PCOS have them while others do not. So both of these first two categories of symptoms of PCOS are possible but not reliable indicators of PCOS. So now you're starting to see why the diagnosis is difficult. The earliest manifestations of PCOS reproductive symptoms are evident as soon as you go through puberty. You start having periods, but instead of having regular, predictable monthly periods, you have infrequent, unpredictable, irregular, quarterly periods, or almost no periods. Next, you might decide to get pregnant. But with PCOS, you might discover that you have infertility. Once again, notice that I said you might have infertility. Some women with PCOS are infertile, while others are not. You see how wishy-washy things are with PCOS? If you do happen to become pregnant, you might have complications of pregnancy. These include gestational diabetes and gestational high blood pressure, also called gestational hypertension. And again, all women with PCOS do not exhibit all these characteristics, and those who do exhibit these pregnancy complications do so to varying degrees. Not all women with these pregnancy complications have PCOS, and you cannot actually diagnose PCOS during pregnancy. So this is yet another reason most people miss the diagnosis of PCOS. The final category of symptoms from PCOS is the most important of all. But unfortunately, it's the one that gets the least attention. It's the one about which most women and doctors are completely unaware. These are the metabolic system abnormalities. You may have heard of metabolic syndrome in conjunction with diabetes type 2. Metabolic syndrome is a cluster of metabolic risk factors for cardiovascular disease, hypertension, and diabetes type 2. It manifests as abnormal cardiac lipids, and cardiac lipids include total cholesterol, triglycerides, lousy LDL, and healthy HDL. I gave you an entire video tutorial on these back in the unit on heart attack. That was video number 162. With metabolic syndrome, all of these cardiac lipids head in the wrong direction. Total cholesterol increases. Triglycerides increase. Lousy LDL increases. And healthy HDL decreases. Only 20% of women with PCOS recognize metabolic syndrome as part of their PCOS. And this is a shame because there are dire consequences of metabolic syndrome. Metabolic syndrome increases your risk of cardiovascular disease and heart attack by 2. That means it's double. It increases your risk of high blood pressure by 3. That means it's triple. And it increases your risk of diabetes type 2 by 5 to 10 times. Can you believe that these metabolic symptoms that have such huge negative health consequences are the most ignored aspects of PCOS? But PCOS also causes obesity, and that adds a whole list of additional risks, including heart attack and Alzheimer's. And as you get fatter on the outside of your body, you also get fatter on the inside of your body. You gain fat around your vital organs, most significantly your liver and your heart. Of all the possible manifestations of PCOS, the metabolic symptoms are the most universal and the most serious, but also the most ignored. You can do all sorts of things to manage hirsutism, acne, and male pattern hair loss. And you can do all sorts of things to regulate your periods and get pregnant. But correcting the underlying metabolic abnormalities in PCOS is a much more difficult task. The key is to understand that PCOS is not just a disease of your ovaries. It is a disease of 3 separate organ systems: dermatologic, reproductive, and metabolic. If you look at the whole list of consequences that are due to PCOS, it's shocking. Dermatologic system abnormalities can manifest as hirsutism, acne, and male pattern hair loss. Reproductive system abnormalities can manifest as irregular, unpredictable, infrequent, or absent periods, infertility, pregnancy complications, abnormal uterine bleeding, and increased risk for endometrial uterine cancer. Metabolic system abnormalities can manifest as diabetes type 2, abnormal cardiac lipids, cardiovascular disease, high blood pressure, increased risk of heart attack, obesity, and non-alcoholic fatty liver disease. Okay, I told you earlier that PCOS involves 3 different organs. So which organs cause all these symptoms? Well, your ovaries cause the dermatologic symptoms. Your brain causes the reproductive symptoms. And your fat causes the metabolic symptoms. Remember, PCOS is all about the rule of threes. And that leads us to the next item in the rule of threes. Which hormones cause PCOS? So let's figure this out one system at a time. The first category of system abnormalities with PCOS is the dermatologic abnormalities, including hirsutism, acne, and male pattern hair loss. Well, those are all symptoms that are masculinizing. And if the symptoms are masculinizing, they must be due to a hormone that causes masculinization, right? Indeed, they are. They are all due to excess testosterone that is produced by your ovaries. Now, here I have the inside of an ovary. Normally, ovaries produce estrogen in great big bucket quantities. And they produce testosterone in little tiny cup quantities. But with PCOS, the cups and buckets are reversed. So instead of producing big buckets of estrogen, you produce great big buckets of testosterone. So the first hormonal abnormality in PCOS is high testosterone from your ovaries, and it produces symptoms of masculinization. The second category of system abnormalities with PCOS is the reproductive abnormalities, including irregular, unpredictable, infrequent, or absent periods, infertility, pregnancy complications, abnormal uterine bleeding, and increased risk for endometrial uterine cancer. Without PCOS, your brain produces the two hormones that control your menstrual cycles. Estrogen is in pink, progesterone is in the multicolored line. One of these controls estrogen production, and the other one controls progesterone production. So your brain is what controls the whole show. So, when it comes to your brain, follicle stimulating hormone, here in red, controls estrogen production. Follicle stimulating hormone is FSH. And luteinizing hormone, which is here in green, controls progesterone production. Luteinizing hormone is LH. These are the two brain hormones that control your entire menstrual cycle. So if they're off, your entire cycle will be off. In a normal menstrual cycle, without PCOS, these two brain hormones cause one single egg to mature and ovulate each month. The egg gets bigger and bigger and it ovulates. So here is a whole ovary demonstrating that only one egg matures and ovulates when your two brain hormones control estrogen and progesterone properly. I've represented ovulation with a balloon around the egg to suggest that the egg has actually left the ovary. And here I have the interior of a single ovary from a normal menstrual cycle. And you can see that one single egg grows, matures, and ovulates. Just one egg. So, if you don't get pregnant, the lining inside your uterus, which had gotten thick, sheds, because its only function was to cushion of fetus had you gotten pregnant. Well, with PCOS, one of these two brain hormones is abnormal. Which one is it? Well, it's the LH, the green one. And the ways in which it is abnormal throw your entire menstrual cycle off kilter. So, with PCOS, there is too much LH, the green line, and it's high all the time. Well, that results in low progesterone all the time. So that interferes with the maturation and ovulation of a single egg. And the result is that your ovaries start maturing many eggs, but none of them ever matures enough to ovulate. So you end up with ovaries that are full of partially matured, non-ovulated eggs that form cysts. So here, I have the exterior of a single ovary from a PCOS menstrual cycle, and as you can see, there are many eggs, but not a single one of them is ovulating. There's not a single one with a balloon around it demonstrating that it's left the ovary. And here, I have the interior of a single ovary from a PCOS menstrual cycle. So now, instead of one single egg growing, maturing, and ovulating, there are just many immature eggs, and not a single one of them ovulates. So the ovary is just full of these immature eggs. Most of these immature eggs form a cyst, but they are not ovulatory cysts. They never extrude and leave the ovary. So this is where we get the term polycystic. Poly means many, and cystic means cysts, which are fluid-filled sacs. Polycystic ovaries are ovaries that harbor multiple fluid-filled cysts containing immature eggs. But that's not all. In addition to the multiple cystic, non-mature, non-ovulatory eggs in your ovaries, the persistently low level of progesterone causes your inner uterine lining to get too thick and stay too thick. That's this line way down here that you can't see. You see how it's thick all the time? It's supposed to be getting thick and then getting thin like this in a normal menstrual cycle. So compare the two. One in the bottom row here stays thick all the time. So that's what's happening with PCOS. So that lining doesn't shed on a predictable, regular basis because there's no predictable hormone cycle. So it just keeps getting thicker and thicker and thicker. And then maybe it'll finally shed, but that'll result in infrequent periods about every 3 or 4 months or so. And they're abnormally heavy if you end up shedding at all. Or you might not shed it. If that's the case, your lifelong extra thick inner uterine lining adds up to a very high risk of endometrial uterine cancer for the rest of your life. See how it all makes sense? You see, in this video, I've given you all of this in somewhat of an abbreviated format. Please, please, please go to the unit on PCOS to get all of this in greater detail. Video number 456 breaks all of this part down for you very, very well. Okay, so well, if you decide to get pregnant at some point, PCOS will likely cause infertility. Most women with PCOS have to resort to fertility drugs and assisted reproduction in order to get pregnant. And then if you do get pregnant, the underlying cause of PCOS puts you at very high risk for the complications of pregnancy like gestational diabetes and gestational hypertension. So the second hormonal abnormality in PCOS is high LH from your brain, and it produces symptoms of menstrual and reproductive abnormalities. Our third and final abnormality in PCOS is the metabolic category. With PCOS, it's your fat cells that produce the metabolic abnormality, and the hormone that is abnormal is insulin. It's not a problem of insulin production. It's a problem of insulin utilization. Your fat cells do not know how to use insulin. So, you deposit fat in your abdomen. Boom. And that makes you perpetually obese. Most women with PCOS have had difficulty losing weight their entire lives. And once your fat metabolism of insulin is all out of whack, any number of other things can happen, all of which constitute metabolic syndrome. You can develop diabetes type 2. Your cardiac lipids such as cholesterol, triglycerides, lousy LDL, and a healthy HDL can all start heading in the wrong direction. This puts you at high risk of cardiovascular disease. Your blood pressure can start rising, and all of this significantly increases your risk of heart attack. Unfortunately, even if you never have the dermatologic or reproductive abnormalities of PCOS, you will probably have underlying metabolic abnormalities. This is why it is so important to get a diagnosis as early in life as possible. So the third hormonal abnormality in PCOS is high insulin from your fat cells, and it produces symptoms of metabolic syndrome. So it's the rule of threes. Your ovaries produce too much testosterone, which causes masculinizing symptoms. Your brain produces too much luteinizing hormone, which causes reproductive symptoms. And your fat cannot utilize insulin, which causes metabolic syndrome. So how do you diagnose a disease with so many different possible manifestations that vary widely from one PCOS patient to the next? Well, first, the doctor, your doctor, needs to listen to you, the patient. And that means you need to speak up. Tell your doctor all about your symptoms. Don't be shy. Don't be vague. Give details about your skin, hair, periods, fertility, weight issues, you name it. Second, your doctor needs to perform a physical exam to assess your skin, hair, and body type. Third, your doctor needs to order a long list of lab tests on you. They include all the following: FSH, LH, LH-FSH ratio, total testosterone, free testosterone, sex hormone binding globulin, dihydroepiandrosterone sulfate, or DHEAS, prolactin, estrogen, cholesterol, HDL, LDL, triglycerides, thyroid stimulating hormone, glucose, insulin, and hemoglobin A1C. But just as with the dermatologic, reproductive, and metabolic features of PCOS, these lab results can vary greatly from one PCOS case to another. There is no one specific lab that nails the diagnosis. This is yet another reason people miss the diagnosis so much. But at least there are some labs that can help make the diagnosis, and generally speaking, there are 3 labs that are the most typically the abnormal ones. The LH-FSH ratio is high, This means that your LH is high, but your FSH is normal. Your total and free testosterone are high. This means that you just have too much testosterone, period. And your hemoglobin A1C is high. Hemoglobin A1C is a measure of insulin levels over a 3-month period of time, so it's just a blood test. So, the 3 most common abnormal labs are high LH-FSH ratio, high testosterone, and high hemoglobin A1C. Now, I've been harping on the rule of 3s, but if you haven't noticed, there is nothing whatsoever that is good about this rule of 3s. All it does is complicate things. So in keeping with the rule of 3s, instead of using everything available to nail the diagnosis of PCOS, everybody focuses on just these 3 labs. And the problem is that you cannot cross PCOS off your list of possibilities even if these 3 labs are normal, even if all the labs are normal. Another diagnostic tool is a pelvic ultrasound. If you happen to have cysts in your ovaries, a pelvic ultrasound can possibly detect them. The problem is that many women with PCOS do not have multiple ovarian cysts. And with the very name of the disease being Polycystic Ovary Syndrome, some doctors do not realize that you can have Polycystic Ovary Syndrome without polycystic ovaries. Even though PCOS commonly causes infertility, some women do achieve pregnancy. And once you become pregnant, there's no way to diagnose PCOS during pregnancy. Add that to the fact that the common pregnancy complications of gestational diabetes and gestational hypertension are not unique to women with PCOS. They occur for all sorts of reasons. So I have now given you a long list of different ways in which one can make the diagnosis of PCOS. But guess what? Rarely do doctors take advantage of all these things. Instead, in keeping with the short-sightedness on PCOS and all the focus on just your ovaries, the official diagnosis of PCOS rests on only 3 things. Darn rule of 3s again. These are called the official diagnostic criteria. To have a documented diagnosis of PCOS, you are required to have only 2 of these 3 things: high testosterone, irregular or infrequent periods, or multiple ovarian cysts on pelvic ultrasound. That's it. None of the other means of diagnosis counts in terms of the official diagnostic criteria for PCOS. So here's a comparison of all the possible indicators of PCOS versus the official diagnostic criteria for PCOS. See the big difference? There are 18 different possible indicators, of which only 3 are considered diagnostic criteria. So if your doctor only goes by these 3 criteria, and you don't happen to have 2 of the 3, your diagnosis of PCOS gets missed. Tisk, tisk, tisk. Well, how do you manage all this if you're fortunate enough to get an actual diagnosis? You've got 3 separate hormone abnormalities from 3 separate organ systems. So how do you manage all of them? Well, you manage each one separately. That's how. The problem is that very, very few women with PCOS manage all three of them. To manage the high testosterone coming from your ovaries and causing hirsutism, acne, and male pattern hair loss, you take an anti-androgen that blocks testosterone. In other words, it blocks the ability of the testosterone to exert its effects. The names of some anti-androgens include spironolactone, finasteride, and flutamide. All of these anti-androgens get to the root of the problem. They prevent excessive testosterone production by your ovaries, and this is the only way to truly treat the problem. If you merely remove unwanted hair, treat your acne superficially, and stimulate hair growth on your head, you will not treat the underlying problem. To manage your irregular periods, you have to erase your menstrual cycles completely. That's the only way to treat the underlying problem of high LH from your brain. And the best, most effective, truly transforming management option that can treat all these symptoms, as well as the underlying PCOS, is birth control. But there are 3 critical criteria for the kind of birth control that is capable of managing PCOS. First, it must contain both estrogen and progestin. Second, it must be monophasic. Third, you must use it continuously. So the first criteria of the birth control for managing PCOS is that it must contain both estrogen and progestin. Any birth control that contains both estrogen and progestin smooths out the hormonal fluctuations that are off because of your high LH. There are 3 delivery systems for birth control that contains both estrogen and progestin. There are dozens and dozens of birth control pills. There are 2 birth control patches, one of which is also available as a generic. And there is only one birth control vaginal ring, which is also available as a generic. With any of these estrogen plus progestin birth control methods, instead of harvesting a crop of immature eggs and failing to ovulate any of them, your ovaries do not embark on attempting ovulation at all. So let me give you a word or 2 of caution. If you have PCOS, you do not want any birth control option that consists of progestin only without estrogen. Nor do you want any kind of progestogen that is not a form of birth control. Nothing that contains progestogen only will have any effect on treating the actual underlying PCOS. Progestin-only birth control includes all the following. Any progestin-only birth control pill, also called the mini pill, progestin shots known as Depo-Provera, progestin implants called Norplant, Nexplanon, or Implanon, and progestin intrauterine devices, or IUDs. So if you even suspect that you have PCOS, do not fall prey to any doctor who tries to give you any of these. They will do nothing at all beneficial for your PCOS. The only kind of birth control that benefits PCOS is one that contains both estrogen and progestin. And because the whole purpose of treatment is to avoid ovulation and prevent thickening of your endometrium, there's a particular way of using estrogen plus progestin birth control for treating PCOS. you have to realize that PCOS messes up your hormone cycles. So the very best way to treat PCOS is to erase your hormone cycles altogether. So that brings us to the other two critical characteristics of the right birth control for doing this. The second requirement is that the birth control must be monophasic. Now, this particular requirement applies only to birth control pills. Birth control patches and birth control vaginal rings are automatically monophasic, but birth control pills are not automatically monophasic. Birth control pills can be either triphasic or monophasic. Monophasic means one phase. One phase simply means that all the active pills contain the very same dosage combination of estrogen and progestin in every pill. Monophasic birth control pills look like this. Notice that all these active pills, they're the white ones. Notice they're all the same color, white. These brown pills are all placebo with no hormones in them at all. We're not talking about those right now. We are only talking about the white pills. A monophasic birth control pill will create hormones that are always consistent with no variation from day to day. And that will prevent incomplete maturation of multiple eggs. The other big benefit of monophasic pills is that they prevent your endometrial uterine lining from ever thickening. It stays like this instead of like this. You see, estrogen alone functions as fertilizer to make their inner uterine lining thick. It's like fertilizer for grass. Progesterone or progestogen alone functions like a lawnmower to shed the thick lining. Well, by having the fertilizer and the lawnmower together, by having the same dosage combination of both estrogen and progestin in every pill, the lawn never grows. So instead of varying between fertilizing and mowing the lawn, you have both the fertilizer and the lawnmower in every single white pill, so the lawn never grows. In other words, your hormones are the same every single day. So you accomplish all your goals with monophasic pills. What you do not want is triphasic pills. They look like this. See, this package has 3 different colors for the active pills. There's pink, yellow, and blue. This is what we call triphasic. Triphasic means 3 phases. 3 phases means that all of the active pills do not contain the very same dosage combination of estrogen and progestin in every pill. Instead, every color contains a different estrogen plus progestin dosage combination. So a triphasic birth control pill will create hormones that are always changing with variation from day to day and color to color. But that means your hormones will be on a roller coaster. And if your hormones are on a roller coaster, your whole life will be on a roller coaster. So you do not want any birth control that has tri or 777 in the product name. Okay, so the first critical characteristic of the right birth control pills for PCOS is that they must contain both estrogen and progestin. And the second critical characteristic is that they must be monophasic. What about that third critical characteristic? Well, this pertains to how you use the birth control. And the way in which you use the birth control is the regimen. The regimen is something that is not automatic with any birth control containing both estrogen and progestogen. You choose the regimen. On several occasions in the past, I've taught you about hormone regimens. The hormone regimen refers to whether you use your birth control in a manner that produces a period or prevents a period. A cyclic regimen produces a period. A continuous regimen prevents a period. So let's discuss how these two regimens affect PCOS. Let's start with birth control pills. You see this package of monophasic birth control pills? Notice that all the active pills are white and that these last few pills are brown. Well, the brown pills are placebos. They're fake. They have no hormones in them at all. So if you take the brown pills, you are using a cyclic regimen and you will have a period. But it makes no sense to have a period. Why not? Because all the monophasic white pills contain both estrogen and progestin. In other words, they all contain both the fertilizer and the lawnmower in the same quantities. So that means that the grass never grows. So there's nothing there to shed. It's always thin. Your lining is always, always, always thin or barely there. There's no benefit in having a period to shed the lawn if the lawn hasn't grown in the first place. And the only thing you accomplish by having a period is a period of time without hormones. The whole key to treating PCOS is to keep everything as stable as possible. You do not want roller coastering hormones or lawn thickening, and you do not want periods of time without hormones. Now, the alternative to a cyclic regimen is a continuous regimen. If you throw away all of these fake brown pills and just take a real pill every single day, a white pill every day, and when you get to the brown ones, you just start a new pack, then you create a continuous regimen. A continuous regimen means that your hormones are the same every single day. You never ever go without hormones. So instead of alternating between having hormones and having no hormones, you get a nice flat line of stability. And that's the kind of stability that treats PCOS. If you don't want a pill, there are birth control patches and a birth control vaginal ring that contain both estrogen and progestin. There are dozens of pills, but only 2 patches and 1 vaginal ring. If you use the birth control patch, you stick a new patch to your skin every week. You leave it there for 1 week. And for a cyclic regimen, you would wear the patch for 3 consecutive weeks. And then you would omit the patch for 1 week, during which time you would have a period. But you don't want periods. Your body has never wanted periods. So instead of skipping a week, you just wear a patch every single week and you never, ever, ever go without it. If you use the birth control vaginal ring, you insert the ring into your vagina. And for a cyclic regimen, you would take the ring out for 3 weeks and leave it out for 1 week. And during the ring-free week, you would have a period. But you don't want periods. So instead of going without the ring for a week, you just insert a new ring every 3 weeks when you remove the old ring. You never, ever, ever go without it. With the birth control patch or vaginal ring, you just use the patch or vaginal ring all the time, never ever skipping a week. So the kind of birth control pills that can actually treat PCOS must meet all three criteria. Must contain both estrogen and progestin. It must be monophasic, and you must use it on a continuous regimen. The brand of your product does not matter. Just find what works best for you, and this is the kind of thing I can help you with in a consultation. To manage your infertility, you go to an infertility specialist. They will get you pregnant, but nothing they do will help your PCOS in any way. You'll still have it during and after your pregnancy. And finally, How do you manage the metabolic abnormalities that are due to excess insulin from your fat cells? Well, there are 3 parts to metabolic management. The first metabolic treatment item is an insulin sensitizer. These are the drugs that people take for diabetes type 2. Names of these drugs include metformin, semaglutide, pioglitazone, rosiglitazone, orlistat, and sibutramine. The second metabolic treatment item is a statin to lower your risk of heart attack. And statin drugs include all of the following: atorvastatin, fluvastatin, lovastatin, pitavastatin, pravastatin, rovastatin, and simvastatin. And the third metabolic treatment is a means of accomplishing weight loss if you're obese. These include weight loss drugs and gastric bypass surgery. So this metabolic category of treatments includes treatment of high insulin, high risk of heart attack, and obesity, all 3. As you can see, premenopausal PCOS is a really big deal. Do not be lackadaisical or cavalier about it. Never think of it as a single abnormality of a single organ. It is a disease of 3s. 3 abnormalities, 3 organs, 3 abnormal hormones, 3 requirements for treatment. Here's a chart from the PCOS unit to summarize all of this. It's your summary for today. On the left, the 3 rows in the first column designate the 3 organ systems that are abnormal in PCOS. The second column designates the abnormal hormone. The third column designates the source of the abnormal hormone. The fourth column lists the symptoms. The fifth column lists the official diagnostic criteria. The sixth column designates the management options that can actually treat PCOS. And the 7th column designates the management options that cannot actually treat PCOS. Please be sure to watch all the videos in the PCOS unit, 455 through 460. That's 6 separate videos compared to this one, so they are much more detailed. You can find the chart in the description box just below the screen, or you can go to menopaustailor.me. And if you have PCOS, or even possibly have PCOS, you need all the detail you can get. Please schedule a consultation with me at menopaustailor.me if you have any inkling whatsoever that you have PCOS, or even if you might have had it in the past. I have focused today's material on the phase of premenopause, but PCOS continues into perimenopause and postmenopause, and that's when it exerts its deadly effects. So please subscribe to my channel and to my newsletter, and please find me on social media, and I will see you in 1 week to discuss premenopausal uterine fibroids. Bye for now, my dears.